Okay, so we are going to continue our talk of diuretics. One of the things I wanted to point out on this chart, and obviously everything with hypertension is kind of circuitous, and you see a lot of feedback loops and things like that. But one of the things to note here, we mentioned that when you have increases in things like the Renin-Angiotensin system, one of the things you also will see is more aldosterone secretion, and then that will also lead to things like more potassium loss from the kidneys, and we'll see some pictures of why that is. But one of the things you can potentially see is hypokalemia from this. So we'll see some of the medications diuretic-wise specifically that will have an effect on potassium, leading to our potassium-sparing diuretics. So it's pretty obvious what they're going to be doing there. So essentially what we'll end up seeing is that this is going to be more in the collecting duct. You'll see a lot of these working. And so essentially what action we're having here is you're blocking the effects of that inward sodium channel. So again, more sodium out in the lumen, you're going to see more water flow that direction, thus more urine flow. You see this is kind of this antiporter kind of situations happening here where sodium comes in and potassium's leaving, and that's affected by aldosterone, right? So the more aldosterone activity there is, more of that potassium you're having coming out, more sodium coming in. So when we're giving these potassium-sparing diuretics, the first group we'll talk about specifically are acting to block that sodium channel. So again, you'll see pretty modest increases in urine flow when you have potassium-sparing diuretics on board. So really, if you're looking at as far how much bang for your buck you get out of a single drug, loop diuretics are probably like your biggest one as far as increasing fluid release. Thiazides probably follow that, and then you have these kind of guys which are pretty modest in general. But the big thing is here is they will have potassium-sparing effects, and you'll actually end up increasing your potassium levels potentially here. The two drugs that fall into this category, you will not often see them used by themselves, but they have amiloride and triamterene. Frequently, you'll see them in combination with things like HCTZ or hydrochlorothiazide. So that way, you're getting kind of synergistic activities. And if you remember, what do thiazides do to your potassium levels? Actually lead them to drop. So if you have a thiazide diuretic which leads potassium to be excreted, and then you have something that's causing more potassium recycling, more reabsorption, thus you may have a little bit more of a neutral effect on your potassium levels, right? And this is going to be really important for your patients who are more prone to things like arrhythmias and whatnot. So potassium homeostasis is a big thing. Again, you're going to see the indications are going to be pretty similar to some of our other diuretics. You'll mainly see these being used more in situations of hypertension, not necessarily specifically for fluid overload. And again, you'll see them often in combination with other medications. It would be very odd if you saw someone who was on this alone for hypertension. So again, usually in combination. Obviously, adverse effects-wise, you would expect them to see hyperkalemia being on that list because of its actions there within the collecting duct. This can be exacerbated by other medications, which we'll talk about today, including your ACE inhibitors. Angiotensin receptor blockers will be on that list as well. And then also if your patients are taking potassium supplements, right? So that can be a big thing where, if they've been on diuretics for a while, they might be on potassium supplements in order to help kind of maintain a normal potassium level in the blood. And so if you were to add this drug on board, that might actually tip things in the scale of having more hyperkalemia. Or if they have changes in renal function over time, they may not be excreting as much potassium as they were otherwise. Again, that could lead to hyperkalemia. Very similar to what we saw with glucose intolerance from your other medications. Same thing's happening here. But one of the kind of unique things here with triamterene, you can actually see megaloblastic anemia. So it's kind of unique compared to a lot of the other diuretics we'll see there. Of course, we've kind of mentioned aldosterone. We see that normally what aldosterone is going to be doing is acting as a steroid. It's going to be binding to the receptors and then get translocated into the nucleus, specifically kind of in the distal convoluted tubule and more importantly in the collecting duct. Once it's there, you're going to be seeing it put more of those sodium channels into the membrane. So the ones that the potassium-sparing diuretics are blocking is putting more of those channels into that membrane. Then you also see more activity of that sodium-potassium ATPase pump. Again, that's an active pump that requires ATP in order to shuttle sodium back into the bloodstream and gets potassium brought into the cell. So by doing that, again, you can imagine by increasing your aldosterone content, especially if you're having, ramping up your Renin-Angiotensin system, this is going to lead to a lot of sodium reabsorption and more potassium being spilled out in the urine. So again, here you can see where it's kind of acting here. It'll bind to the cell and then get translocated and then act within the nucleus itself to cause changes in gene transcription and whatnot, and have more of those sodium channels put there in the membrane. And this is on the right side, that's that sodium potassium ATPase pump I was mentioning, where again it's shuttling things against its concentration gradient, which is why it takes ATP to work. It's an active process, and so it's shuttling sodium out into the bloodstream and then potassium into that cell in order for it to be released into the urine. We'll talk about other drugs that have effects on the sodium potassium ATPase pump, namely digoxin is going to be one of the big ones there. So two drugs, specifically they're working as aldosterone antagonists, will be spironolactone and eplerenone. So again, they're going to be working specifically by antagonizing the effects of aldosterone. So they'll bind to the steroid receptor on the actual cell membrane, but they don't get translocated and have the same effects that aldosterone does. There's some lag time for them to work, and they typically work better when you have a situation where your aldosterone levels are already high to begin with. So in a patient whose Renin-Angiotensin system was already kind of ramped up, this would work better than someone who had, say, no hypertension, and the aldosterone probably isn't all that increased over normal. You'll also end up seeing a decrease in the loss of potassium. So again, you're going to have potassium-sparing effects, similar to what we saw with the other guys. And then you'll actually see some increase in calcium excretion, so you can see some losses there. Again, modest effects on lipids, on glucose, and on uric acid levels. And again, as far as the actual diuretic effect, pretty modest in comparison to something like your thiazides or your lubes. So clinical uses, if you were to have a situation where you had a primary aldosteronism, this would be a good drug in order to help blunt some of those effects. You'll see it used in hypertension. And then in CHF, or congestive heart failure, you'll end up seeing these being used, especially in kind of later stages. There are some mortality benefits, potentially, for your kind of late stage CHF patients, where having a aldosterone antagonist has some mortality benefits. And we'll talk about that when we get to our CHF section, probably in the next unit, or in the next actual section of the class. You'll also see it used for some edematous conditions, so again, like cirrhosis, where you're having a lot of ascites and fluid overload. Nephrotic syndrome might be another place where you'll see it being used as well. Adverse effects are pretty similar to what you would expect to see with the potassium-sparing diuretics. Hyperkalemia can certainly occur. You also potentially see a mild acidosis develop there. The big things to note with the aldosterone antagonists, which set them aside from the other groups of diuretics, is this kind of weak androgenic effect. So it kind of works as like a partial agonist at the androgen receptors. And so what you're going to end up seeing is that, for guys who have a lot of testosterone, you're going to be seeing kind of decreased testosterone effects. And then for ladies who don't have as much testosterone, you're going to be seeing kind of increased testosterone effects. So what that means is that for guys, you can see gynecomastia, testicular atrophy, which can occur, which are pretty big side effects that a lot of people will stop taking the medication for. And then in women, you can see hirsutism, so abnormal hair growth, and some menstrual irregularities. So you see that more with spironolactone, especially with higher doses. So as you ramp up your dose, you're more likely to see these kind of weak androgenic effects. Yes?
How come they get acidotic when HCO3 is coming in with the potassium?
Basically, they end up, at some point, you end up losing some of that bicarbonate. So you don't really see like a contraction alkalosis like you would end up seeing with like a lot of your other diuretics. You just end up seeing kind of a mild acidosis. Clinically, you don't really see it pop up all that often, so it's something your body can compensate for. So clinically, it's not all that relevant. With these, you see eplerenone having less effect of this, but it's also kind of the newer, more expensive drug. So usually you'll try spironolactone first. If that doesn't work, then you can potentially try out eplerenone as an alternative. The next group we'll talk about, these are going to be working way back in the proximal convoluted tubule. These would be our carbonic anhydrase inhibitors. Does anyone remember where we ran into these guys before? Yeah. Glaucoma, absolutely. So we see these drugs working here as well. So these obviously are going to be working by inhibiting the effects of carbonic anhydrase, which, remember, what does carbonic anhydrase do? It combines water and CO2 to form bicarbonate and vice versa. So it's a two-way street there. But essentially what we're going to end up seeing is that in the proximal convoluted tubule, it's going to increase the amount of bicarbonate being released within the urine. So we'll show you a picture of that in just a second here. Again, as far as the diuretic effect, it's pretty minor, and so you would rarely see someone being put on this specifically as a diuretic effect or as an antihypertensive by itself. But the three that you'll see in this group, and really I highlighted acetazolamide because clinically this is the one you're going to see used most often, so this is the one I'd probably use most of my, put most of my memory towards. Acetazolamide or Diamox is a fairly common one you'll end up seeing being used. So just to show you the picture here, so again on your left side you'll have your lumen, and then on the right side your interstitial space, kind of going back to the bloodstream. Basically what you end up having done is on the outside, and on the left picture here, this is kind of the normal state which it would be in. Normally you'd have carbonic anhydrase. Normally bicarbonate has a harder time being reabsorbed into the cells, and so if you use carbonic anhydrase to actually break that down into CO2 and water, that's a lot easier time being reabsorbed. And then once it's in the cell, then it can be acted on by carbonic anhydrase again to form the bicarbonate and then be shuttled back into the bloodstream along with sodium. So you see that transporter there. When you have something like acetazolamide on board, you're inhibiting that process, and so all the bicarbonate will end up staying out within the lumen and then where it can be excreted out. So big uses for this is, like we talked about, glaucoma, so things like dorzolamide or brinzolamide, you'll certainly see them being used there. In some cases, I actually will see this being used in some cases of epilepsy. So especially for some of the peds patients I've seen, they're very, very difficult to control epilepsy. You can put them in this kind of mildly acidotic state, and this actually will help to decrease their seizure threshold and prevent them from seizing. So I've seen this used in several cases of very difficult to control seizures. Because obviously by excreting all that bicarb, you're going to induce a metabolic alkalosis or metabolic acidosis. You can also end up seeing potential use for mountain sickness or altitude sickness. So if you take this for a longer period of time prior to going to a big change in elevation, so say if you went to Colorado or something like that, this can actually help prevent some of the altitude sickness you may see there. And then also, by decreasing fluid production within the CNS, you can actually end up having some decrease in swelling, especially for things like head injury where cerebral edema can occur. Obviously, the adverse effects we can see here include the metabolic acidosis, so especially if your patient did not have enough bicarbonate on board, that can cause other problems. Potassium depletion, and then drowsiness is another common one. Okay, and then the last group of diuretics we'll talk about are going to be our osmotic diuretics. So these are things that get filtered in the glomerulus, but they do not get reabsorbed once they're in the actual rest of the nephron. So they will basically are kind of high solute kind of solutions that will end up drawing water along with them, and so it inhibits H2O reabsorption in the proximal convoluted tubule. So just drawing a lot of water into the lumen where it can be excreted. So again, a lot of these items are going to have pretty high tonicity for the most part. So the big ones you'll see being used here include things like mannitol, glycerin, isosorbide, and even urea can be used here as well. So the one I see clinically being used, and really you don't see a lot of these being used as diuretics necessarily, you'll see these being used sometimes for other cases. So mannitol is one I would see most frequently, in which case you're actually using it for things like cerebral edema, secondary to head injuries, and things like that. So oftentimes clinically you will not see these used specifically as diuretics, but that's just a kind of an effect they have. So if you were to have someone who, say, has acute renal failure or acute tubular necrosis, this will definitely help to increase urine output, but actually fixing the kidney issues there is, it's of questionable efficacy. So not seeing used too frequently there, but certainly if you're having acute pressure issues that are due to volume overload, things like cerebral edema, acute glaucoma, sometimes you can use these agents to help draw fluid out of those spaces in order to decrease that pressure, right? So by having things with really high tonicity, things like mannitol, you can draw water out of things like the CNS and help to decrease that pressure. Okay, any questions on diuretics? Anyone have to go to the bathroom? No, good, all right. All right, so next we'll talk about our renin-angiotensin aldosterone system inhibitors. So we know that the renin-angiotensin system is responsible for lots of things within the body. So it helps with blood pressure regulation, helps with secretion of aldosterone, renal blood flow, sodium excretion, even see some effects on the autonomic nervous system. There's tissue angiotensin systems. It's important for fetal development. It's important for lots of different things within the body. But the blood pressure effects are the big ones we're going to be focusing on here. So basically what's happening here is that the kidneys, whenever they are sensing that there's not enough blood flow coming to them, there's a couple different receptors that we'll talk about in just a second. Essentially what they're going to do is start to excrete renin. So renin is going to activate the conversion of angiotensinogen over to angiotensin 1. Okay. Angiotensin 1 is not really the big molecule we're really worried about, but the thing we are going to see converted over to is angiotensin 2. And that's being done by the angiotensin converting enzyme, or ACE. So angiotensin 2 is a very potent vasoconstrictor, and that's what we're mainly going to be targeting when we're using our antihypertensives, is preventing either the formation of angiotensin 2 or blocking the effects at the receptors where angiotensin 2 would actually be activating, right? So angiotensin 2 is also going to lead to things like release of aldosterone, lead to vasoconstriction, and so we want to help to blunt that effect as far up the chain as possible. Another important thing to note here is that angiotensin converting enzyme is also important for metabolism of bradykinin, and that's going to be important for some of the adverse effects we'll see with our ACE inhibitors. So, what is stimulating renin release? We mentioned that a lot of it is controlled by the kidneys, and so we'll talk about these more in depth, but you'll see things like renal baroreceptors, the macula densa in the kidney, and then also the sympathetic nervous system are the main things that are influencing renin release. So the renal baroreceptor, again, that is going to be responding to basically the stretch that's occurring in that afferent arteriole. So if you're having decreased renal perfusion, so say you lost a whole lot of blood and you're having decreased renal perfusion because that afferent arteriole, which is going into the glomerulus, is just not being filled quite so well, that's going to stimulate the kidneys to say, hey, we need more fluid coming here, we need to have more vasoconstriction, to send more volume this way, so let's go ahead and start to increase renin release. Okay, so that's one way that it will occur. This is also why you would end up seeing things like NSAIDs increase renin release, right? Because we said NSAIDs are affecting prostaglandins synthesis in the afferent arterioles. So we said prostaglandins are normally vasodilatory. So if you were to blunt that with an NSAID, you have more vasoconstriction, and that's that baroreceptor says, hey, there's not enough stretch here. Let's go ahead and produce some more renin. The other thing you can see is in the macula densa, they'll be responding to changes in sodium and chloride in the distal tubule, and so this will actually help to stimulate renin release as well. So decreases in sodium or chloride can do that. And then with the sympathetic nervous system, the renal nerve helps to control release here. They'll be innervating these juxtaglomerular cells, and then you'll see that the sympathetic activation will also increase renal release as well. And that's a lot of it has to do with beta-1 receptors increasing that release. So three things all increase renin release in the end. So you can see where a lot of our antihypertensives can kind of go back and help to stimulate this release of renin. So if you're affecting anything with the afferent arteriole, you're going to see increases in renin, which kind of blunt the effects of your antihypertensive. So we said angiotensin 2 is a potent vasoconstrictor, and they influences release of aldosterone. So again, we saw that was controlling, sodium and water excretion within the kidneys. Also cause renal vasoconstriction, and then it actually has a negative feedback loop where production of angiotensin 2 will actually inhibit the release of more renin. So once the kidney gets the idea that you have enough angiotensin 2 around, it says, oh, I don't need to release as much renin anymore, and you have a blunting of that effect. And also you'll see some increase in sympathetic outflow via kind of a more central CNS action. They'll work to increase release of things like norepinephrine by acting on some of these presynaptic receptors. It'll work by stimulating thirst, so especially with things like ADH secretion, which we said is antidiuretic hormone. It's a very potent stimulator of thirst. And then also it can help to cause some cell and tissue hypertrophy, even cardiac remodeling after MI. So this is where we see a lot of issues, especially post-MI, and we see worsening congestive heart failure is with a lot of that remodeling. So by having angiotensin 2 here, it's really responsible for a lot of that. So if we can blunt that effect, potentially we can have some positive effects on remodeling on the heart. So again, overactivity of the renin-angiotensin system can lead to hypertension, CHF, diabetic nephropathy, so especially with some of those little microvascular complications, and then also myocardial remodeling post-MI. So lots of bad things are responsible because of angiotensin 2. And so anything that can reduce the activity of that renin-angiotensin system can have positive effects on morbidity and mortality. So these are going to be important drugs to make sure your patients are on if they fit certain criteria. So even if they don't have things like hypertension, potentially you can use these drugs to help prevent other complications of things like diabetes, etc. So by inhibiting the actions of angiotensin converting enzymes, some of the things we're going to see is less Ang2 vasoconstriction, right? Because there's less Ang2 actually being produced. We'll see less renal vasoconstriction, less synthesis of aldosterone, less sodium reabsorption. We'll have less of this increase in norepinephrine release due to Ang2, and we'll also have less bradykinin metabolism. And then we'll also see it end up having a decrease in that negative feedback loop. So even though you're producing more renin, in the end, you're still blocking that enzyme from producing more angiotensin II. So it's kind of a net positive in that result. So our ACE inhibitors, you're going to see there's quite a few of them. They all have an identical mechanism of action and effects. You're going to see differing things like half-life, different things in metabolism. A lot of them end up being prodrugs, so they end up having to be converted in the liver to their active forms. The only two exceptions to that would be something like captopril and lisinopril. And then most of them are going to be eliminated through the kidneys, except for fosinipral. It's actually going to be more in the liver. So here are our the first list of our ACE inhibitors. You'll see that when they are the inactive form, you'll have something like enalapril, lisinopril. When they get into the activated form in the liver, they have that AT added to the end. So enalapril will get activated over to enalaprilat. Okay. The one thing to note is that the IV form, there's only one ACE inhibitor that I'm aware of that is available IV, and that's enalaprilat. So it actually comes as the active form, so you can just inject that intravenously, and it's already active. It doesn't have to be converted by the liver before it becomes actually therapeutically active. So that's a good short-term kind of antihypertensive you can use if you need to administer something intravenously. And the rest of the list, you can see at least they're pretty easy to pick out of a list. If you see the pril at the end, chances are it's probably an ACE inhibitor you're dealing with. Okay, so you'll see that most ACE inhibitors will require just once daily dosing. So this is also another benefit of them, is that it's a little bit easier to administer. Except captopril has a fairly short half-life, so you may see twice daily dosing of that one. In which case, you end up seeing kind of reduction of effects as you get later in the day, which would kind of prompt you to do another dose. So most of the time, you'll end up seeing a lot of ACE inhibitors are they're just being given once a day just because it's easier for your patients. You end up seeing kind of at lower doses, kind of a steep dose response curve, meaning that if I have small changes in dose, I'm going to see big changes in their blood pressure. But once you kind of top out, you'll end up hitting that plateau where even changing your dose really leads to a pretty flat dose response, right? So you kind of have a window where things will be having kind of big effects, and then it's going to plateau out. So there's no point really increasing your dose past that. So our therapeutic uses, big ones are going to be for hypertension. That's kind of what they're originally designed for. They're decreasing total peripheral resistance. They're decreasing our systolic and diastolic blood pressure by reducing the effects of angiotensin II. And they can also help to decrease left ventricular hypertrophy due to this elevated pressure, right? Which we know is a big reason for CHF developing, is due to that left ventricular hypertrophy. And this is also going to be preferred in your diabetics, mainly because of the kidney protective effects. It's going to kind of help, it doesn't help reverse any of the nephropathy that might have already occurred, but it helps to prevent it from progressing further. Other uses, we can see this being used for congestive heart failure. So again, like you said, it decreases a lot of that left ventricular remodeling and hypertrophy. It's also going to help to decrease that vascular resistance that your heart's pumping against, so it's going to decrease afterload. And so you'll also end up seeing, just due to venous dilation, you're going to see decreases in preload and increases in cardiac output. So really good things for your CHF patients. And by preventing that remodeling, you're going to prevent further damage, hopefully prevent further damage from occurring, or at least slow it down. So you're going to see decreased incidence of MI, hospitalizations due to this. And so basically, unless they have some other huge contraindications, you really have most of your CHF patients with LV dysfunction being on an ACE inhibitor. So you can see here just kind of the circuitous nature of heart failure and renin release. But basically the whole point is just to show that by having more renin, having more angiotensin effects, you're going to lead to more cardiac remodeling, which is going to worsen your heart failure, which worsens your cardiac output, which stimulates more renin release. So it's kind of this circuitous nature that you can at least blunt by inhibiting the effects of angiotensin II. You'll also see ACE inhibitors being recommended post-myocardial infarction, so it helps to decrease myocardial remodeling following an infarction, and then will help to decrease overall mortality when given post-MI. So it's a really good thing for you'll end up seeing when you're out in the clinical world that when patients are post-MI, they'll have a lot of like benchmarks, certain medications they need to be on, certain benchmarks they're meeting, and so things like having an ACE inhibitor on board is going to be one of those big ones to make sure they have, because otherwise, by giving that to them post-MI, you can hopefully prevent further hospitalizations and things like that down the road. Bless you. As far as diabetic nephropathy goes, so by decreasing glomerular pressure, you can decrease a lot of that that pressure damage that occurs to the glomerulus over time, and it's also help with further remodeling of the kidney as well. So again, it's going to help prevent or delay progression of disease, but it's not going to really reverse anything for them. So if they already have really crappy kidneys because they've been diabetic and hypertensive for 40 years, this isn't going to reverse that, but it may help to stave it off from getting worse over time. Also going to help with some other than just basically slow progression is really the big thing there. So as far as side effects go with your ACE inhibitors, pretty much they're well tolerated, but this dry cough is going to be a big thing that will turn a lot of people off of it. So anywhere between 5 and 15% of patients will end up having this dry cough. And a lot of it's thought to be due to, by inhibiting the breakdown of bradykinin, you have a buildup of that, and also this other substance called substance P, which leads to an accumulation in the lungs, and that's what's stimulating that cough from occurring. So usually you can see it within 1 week to 6 months of it developing, and it's not really related to a dose or a specific agent. It's really just related to that bradykinin buildup there. May see it more frequently in women, although I've known plenty of men who've had that issue as well. And so in a lot of cases, it just is so kind of bothersome to their quality of life. They just say, hey, I can't really deal with this. So either stop taking it or you switch them over to something else, which we'll talk about an alternative that will be useful for that. It's really kind of like my cousin was on an ACE inhibitor for a long time, and it's really annoying to even be around him when he was on it, just because it's dry hacking cough like constantly. So nothing really fixes it. So he ended up going over to an angiotensin receptor blocker, which is better for him because he led to a lot less side effects there. So definitely occurs. Other things, because we are inhibiting the effects of aldosterone secretion, you end up seeing increased potassium levels. So for patients who do have renal disease, or those that are taking other potassium-sparing drugs, or those that are taking potassium supplements, you may run the risk of having hyperkalemia, which can be an issue there. And then you also worry about hypotension as well. So you may see this with, usually patients will see this mostly with the first dose, and they'll kind of get tolerant to the effects after a while. You see this more in patients who may be kind of fluid depleted or sodium depleted, or if they're on multiple medications already for their blood pressure. So again, a lot of times you may recommend patients take the first dose at nighttime so they can kind of sleep through that initial hypotension, and then they kind of get used to it over time. The renal function impairment is another important thing. So we mentioned the afferent arteriole is being controlled a lot by the prostaglandins, which prostaglandins are normally vasoconstrictive or vasodilatory. Usually vasodilatory, right? Because you want more blood going to the kidneys in the afferent arteriole. So usually prostaglandins are vasodilatory, and that's why the NSAIDs cause decreased renal blood flow and potentially can harm your creatinine clearance because of that. On the efferent side, or the thing heading out of the glomerulus, angiotensin II is really responsible for a lot of that vasoconstriction. And so it's basically causing a lot of that back pressure on the glomerulus that causes that filtration to occur. So if I were to say take away the angiotensin vasoconstrictor and vasodilate that, you have less filtration potentially that's occurring there at the glomerulus. So it's basically kind of pinching off a hose, and then all of a sudden you take all that pressure off of it, right? So for patients who are really that need to have angiotensin II around in order to help facilitate that filtration, if you were to take away that Ang2 effect immediately, you can see a kind of a sudden decrease in their creatinine clearance. And so for those patients, you really want to start at lower doses and gently titrate up to their therapeutic dose. Otherwise, you can see a big drop in their kidney function, which can be problematic. Does that make sense, that mechanism? So really think about with the afferent arteriole, prostaglandins are responsible for vasodilatation, and on the efferent arteriole, Ang2 is really responsible for the vasoconstriction, both of which cause better filtration at the glomerulus. Okay. Other things to be aware of: angioedema is a rare side effect, but it certainly can occur. The way it was described to me is, a third of people will have it, within the first couple weeks of taking it. A couple, and the next third will have it, and then, say a few months of taking the drug, and then the last third may have it years down the road. You can take an ACE inhibitor for years, not have any problems, and then all of a sudden develop this angioedema. So it's pretty significant when it happens. You'll have rapid swelling of the nose, throat, mouth. I remember this one guy when I was in rotations in the ER. He knew he had a reaction to ACE inhibitors, but he was really worried about his blood pressure, so he decided to take it anyway. And just comes in, his tongue is just completely out of his mouth. Everything is completely swollen. Needed to end up intubating him with the fiber optic scope. The swelling was so bad, so it can be very, very serious. Basically, the biggest thing to do is just to remove the drug. That's the biggest thing to help prevent further issues from occurring. Normally people will treat it like a normal anaphylaxis, which we'll talk about in the next section, but just be aware that it can occur at any time, and if patients start to develop these symptoms, they need to get checked out in the ER immediately.
Do the symptoms of allergy sort of present slowly, or does it just...
It seems like it just kind of comes on. Like it's pretty rapid. It's not like you're going to experience itching and all the kind of normal allergic symptoms. It can be pretty rapid. Yeah. And unfortunately, there's no kind of guessing like who's going to be more likely to react than others. So it's just one of those things that happens. Yep. Other big issues with ACE inhibitors is fetal morbidity and mortality. Angiotensin II is really useful for a lot of fetal development, so it's contraindicated, and especially in the second and third trimesters, led to fetal death and birth defects. So it's really important to make sure patients are not going to be pregnant while taking these. And then we also mentioned, as far as NSAIDs go, they can decrease those ACE inhibitor effects, again, by blocking some of the bradykinin-mediated relaxation, but also just due to the prostaglandin effects that it has on the afferent arteriole. So you can take an ACE inhibitor. The alternative would be, well, if I can't block the effects of the production of angiotensin II, maybe I can just block the receptors itself. And so that's where our angiotensin receptor blockers basically came from. The other thing is that there's alternative pathways for the production of angiotensin II. There's trypsin kinase pathways. So even though you're blocking the majority of it with an ACE inhibitor, you're not blocking all the production of angiotensin II. So instead, what they act upon are these two angiotensin receptors. So there's AT1 and there's AT2. AT2 is really going to be mainly expressed during development. So you don't see a lot of expression of it in adults. Certainly in fetal tissue, you do see it. The angiotensin 1 is really the more widely expressed one. So you'll see it in the heart, the endothelium, vascular smooth muscle, the kidney. That's really where you're going to see a lot of your AT1 receptors at. And so this is mainly where angiotensin II is going to be functional at. You see here that when angiotensin II activates that AT1, you see that vasoconstriction, the aldosterone, all those clinical effects we already talked about. It's mainly mediated by that AT1. So the angiotensin receptor blockers are going to be a high affinity binding, slow dissociation, sustained blockade of those AT1 receptors. So it's going to lead to all the same effects that we saw with our ACE inhibitors. It's just doing it at a different step in the process. But the one difference here would be, if you remember going back to that bradykinin metabolism, you're not really going to have any effect on that because you're still producing angiotensin II, which can still metabolize that bradykinin. It's just the angiotensin II can't act upon those receptors. So that's why it's probably better for patients to have that dry cough, because it doesn't really affect their bradykinins so much when you have one of these receptor blockers on board. So again, angiotensin receptor blockers are better at reducing the effects of Ang2, specifically at the receptor. You're going to see that angiotensin receptor blockers will indirectly activate these AT2 receptor activation because due to the fact that you're increasing angiotensin II production, a lot of it has to do with that feedback loop where if you're blocking the AT1 receptors, the body's still sensing there's none of renin activity. So you'll end up producing more angiotensin II, which means you can't have more activity at the AT2 receptors. Clinically, we don't know if that's really relevant so much. But the other thing here is you don't see any inhibition of breakdown of bradykinin, which can be advantageous to some patients. And as far as metabolism goes, you see a lot of your ACE inhibitors going through renal elimination, but with ARBs, it's typically kind of split between renal and bile elimination. But again, clinically, it doesn't really come up all that too often. So some of them will be prodrugs, some of them will be non-prodrugs. It's not really important for you guys to memorize which ones are which. I just put it up there for reference. These will obviously be discernible by their names with the artin suffix there, so those are pretty easy to pick out. A lot of them you see will have these salts forms, so if you ever see kind of odd names after them, that's usually just a salt form that they are compounded with. So again, their therapeutic uses, you'll see pretty much all the same uses as you would for an ACE inhibitor. So certainly we'll end up seeing good use for hypertension, CHF, all this good stuff. The other thing you notice with the ARBs is that whereas with your angiotensin receptor, or the ACE inhibitors, you end up seeing kind of a more steep dose response at the lower doses, but with your AT1 receptors, because they saturate those receptors so well and they bind so tightly, you don't really see much benefit of going beyond starting doses. It's really kind of a flat dose response curve in that regard. So even if you have big changes in dose, you won't see as dramatic changes in blood pressure as you might with something like an ACE inhibitor. A lot of those drugs will be compounded with a diuretic, so most often HCTZ will be put in combination with that to help kind of have further synergistic effects on the blood pressure. End up seeing, it's often why you have these patients, you have a thiazide diuretic being put on board because, in general, your ACE inhibitors and your ARBs are less effective for salt-sensitive forms of hypertension, so that's why we end up adding those diuretics, right? In the salt-sensitive patients, there's those that can't really process enough salt from the kidneys, which leads to kind of build up and further hypertension. So using a thiazide plus an angiotensin receptor blocker or an ACE inhibitor is usually makes good therapeutic sense based on their mechanisms. Again, it helps with decreasing left ventricular dysfunction or remodeling that can occur, and also can be useful for staving off diabetic nephropathy. So similar therapeutic uses as you would see with your ACE inhibitors. Side effects are also going to be very similar here, except you don't really see so much of the nagging cough. Renal function impairment is going to be the same activities you would see with the ACE inhibitors, and again, you do not want to give this to pregnant patients. Again, with anything, especially with their CHF patients, you want to start low doses and kind of titrate up gently. You don't see as much angioedema occurring with the ACE with the ARBs as you do with the ACE inhibitor. So some people feel that it's safe if you had a patient who had angioedema with an ACE inhibitor that you could switch them over to an ARB. I think most people are probably skittish about doing that, but in theory it's probably safe to do so. But just be aware that if you see a patient who's had a history of angioedema to an ACE inhibitor and they're on an ARB, that's probably okay because the incidence of angioedema with these guys are very, very low. Okay, so any questions on, yes?
You said that the dose response was nonlinear, so why would it matter if you do that with the heart failure patients?
Because you're usually starting with lower than your normal therapeutic dose, right? So you might start with say half of a starter dose and then kind of gently titrate up. Yeah. Any questions on renin-angiotensin blockers? All right, so moving on, next we'll have our next group, which would be our calcium channel blockers. Can you imagine what they do, what their mechanism is? Probably, yeah, so at least these are a little bit more intuitive than your cephalosporins. How do you figure out what a cephalosporin does based on the name, right? These at least are pretty direct. So there's lots of different types of calcium channels within the body. You'll see that in different areas of the body, they're responsible for different things. So you have your T-type channels, which are important for things like pacemaker depolarization. You have that ryanodine receptor, which is important in the sarcoplasmic reticulum for releasing calcium. Lots of different places. The ones that we're mainly going to focus on are going to be these L-type calcium channels. So this is where all of our calcium channel blockers are going to be working on these L-types. And you'll notice this is going to be important for things like AV nodal conduction. It's going to be important for things like vascular smooth muscle relaxation. And these are the main ones that therapeutically we're going to use for hypertension. So these L-type channels, again, like I mentioned, they're visible or they're present in the vascular smooth muscle. You'll see them in the cardiac myocytes and also in the cardiac nodal tissue. So both in the SA node and the AV node, these L-type channels will be present. So have you guys covered any of cardiac physiology? A little bit. Okay, so I'm not going to go too in depth. I'm mainly going to talk about the role of calcium has on these type cells and where it's working at. So obviously, you have basically your two different types of cells within the heart. You have your pacemaker cells, and you have your basically your cells are being activated by the pacemaker cells, so the kind of the non-automatic ones, all your other myocytes basically. So essentially what you're seeing, and you can look at these kind of blue triangles or rhombuses or whatever they happen to be, that are going to be the calcium influx and efflux out of the cells that are going to help stimulate this point. So again, you look at your pacemaker cells, you know that normally that kind of slow increase in electronegativity is going to be due to sodium influx. There's also some calcium that comes in there, and then when the cell actually fires off, that's when it's going to be a lot of calcium coming into the cell and then gently kind of releasing out. It's kind of a more pronounced effect you'll see in the other myocytes, where mainly the big uptick in that electronegativity is due to the sodium, but calcium is responsible for more of that plateau effect that occurs there, right? So calcium will be kind of have a rapid influx into the cell and then kind of slowly taper off, and that's where you see that plateau effect. And basically the drugs we're going to be using here are going to help blunt the influx of calcium coming into these cells. So if you were to look at the calcium channels in the myocytes, you can see these L-type calcium channels being on the cell surface of the myocytes. When they enter into the cells, into the myocytes, they actually are going to be triggering release of calcium from the sarcoplasmic reticulum. Right, so there's a ton of calcium that's stored in the sarcoplasmic reticulum that comes out, and that's what's going to eventually lead to that muscle contraction. Right, so calcium is really, really important for that. So if you're blunting the amount of calcium getting into the myocyte through those L-type channels, you're going to blunt the amount of calcium coming out of the sarcoplasmic reticulum. Thus, you're not going to get as much of a squeeze on the heart. Right. During the recovery phase, you'll see a lot of calcium going back into the sarcoplasmic reticulum and then being shuttled out of the myocyte so it can kind of go back to its normal resting membrane potential. Here's just another picture kind of showing a very similar thing where if you're blunting calcium coming into the cell, you have less of it coming out of the sarcoplasmic reticulum. There's less of it kind of triggering off the myosin, tropomyosin complex there, so you don't really get as much of a squeeze. The same effect can also occur within the vascular smooth muscle. So we'll see there's a certain subset of calcium channel blockers that work more on the vascular smooth muscle, but by blocking calcium influx, you have less of it coming from the sarcoplasmic reticulum, and thus you have less squeeze on the vascular smooth muscle, which is going to be really important for things like hypertension, right? Because you're going to have less squeeze on that. You want to have more vasodilatation happening. So looking at the effects of calcium channel blockers on veins, you typically see that they're not super great at decreasing venous tone. Right, they're going to be really working more on the arteries more than anything. So at therapeutic doses, calcium channel blockers can decrease afterload, meaning you have less pressure you're pumping against, so you have kind of less effect on, you have more effect on the arteries, and really no effect on preload so much. Right, we'll have other drugs that are going to be affecting preload more than this, but calcium channel blockers are not the ones to do that. On the other hand, though, looking at the myocyte and looking at arterial blood vessels, we end up seeing that they really depend a lot on this calcium influx through these L-type channels and also from the sarcoplasmic reticulum. So by blunting the effects there, you're going to end up seeing that these, especially the arteries, are going to be a lot more sensitive to the effects of these L-type channels being blocked than you would say in the venous system, and even more so than the myocardial cells. So really, these are affecting the arteries and the heart mainly. The veins, really not so much. So we'll see that some of the specific calcium channel blockers are going to work better on nodal tissue. And so you notice two things here. I have non-DHP and DHP. And so DHP means dihydropyridine, right? So dihydropyridine, so you'll have two classes of calcium channel blockers that I'll break them into. So you have your dihydropyridines and you have your non-dihydropyridines. So non-dihydropyridines, those are going to be more working on slowing both the inward current and the decreased rate of recovery. Thus, you're going to end up seeing slowed AV conduction. So your non-dihydropyridine are going to have more effect on the SA node and the AV node to help slow conduction. And thus, what do you expect that would do to your heart rate? Should go down, right? So decreasing that automaticity and decreasing that conduction. So the non-dihydropyridines have much more effect on nodal tissue. The dihydropyridines don't really have any effect on the AV conduction, and thus they're going to have much more effect on, say, the peripheral blood vessels. So you end up seeing that your non-dihydropyridines are typically used more as antiarrhythmics, versus your dihydropyridines are more used purely as antihypertensives because of that differentiation in their effect. Does that make sense? It'll probably make more sense as we go forward.
Can you say that again?
Yep. So non-dihydropyridines have effect on the nodal tissue, meaning the SA node and the AV node. So it's going to slow conduction, and thus they're going to be useful for things like arrhythmias, where you have like tachyarrhythmias. They can help slow that down. Whereas your dihydropyridines are going to preferentially work more on the peripheral circulatory system. They're going to work more on those arteries to help to induce vasodilation, and so they're going to be better for causing just pure antihypertensive effects. Non-dihydropyridines will still have those effects in the periphery. It's just more pronounced with the dihydropyridines. So we'll talk more about that in a second. It should make more sense in just a little bit. So therapeutic uses that we'll see calcium channel blockers being used include angina. That's going to be a big one to help prevent angina from occurring. And that makes sense because if we're having more vasorelaxation, especially of the coronary arteries, that helps to prevent blockages from occurring and leading to that decreased oxygen delivery to the tissue. You see them being used for hypertension. It's probably the most common use. Arrhythmias, so especially supraventricular arrhythmias, and that's specifically going to be with the non-dihydropyridines, right? So it's important to note that. But you can also see it used for things like diastolic heart failure, cerebral ischemia, and even in some cases like migraine prophylaxis, you'll see some of these being used. So this is the breakdown of our calcium channel blockers. So you'll see that the non-dihydropyridines are going to be our diltiazem and our verapamil. Therapeutically, you can think of those two as being the non-dihydropyridines. They have very similar actions. So I kind of lump those two together in one category. And then you have your dihydropyridines, which I'll show you that list in a little bit. And so if you look at their activities, you can see that the vasodilatory actions are going to be much higher with your dihydropyridines. You still get some with your non-dihydropyridines, but it's not going to be as pronounced. And then if you look at the effects on suppressing cardiac contractility, if you look at the effect on the SA node and the AV node, it's going to be much more pronounced with your non-dihydropyridines. Right? So if I asked you which one of these could potentially be used for, say, a supraventricular tachyarrhythmia, you would not say the dihydropyridines because those would really have no effect on the SA or AV node, right? Make sense? So the first one we'll talk about, that's more of the chemical classification of diltiazem, but you can just kind of say it's a non-dihydropyridine. That's as far as I'll expect you to know. But the first one we'll talk about is diltiazem. So this one is available IV or PO. You can end up seeing both immediate release and sustained release preparations. So especially for a lot more long-term control of blood pressure, you see a lot of patients on their SR formulations. Again, this is going to be approved for things like angina, hypertension, and these supraventricular tachycardias. So if you had a patient who say had AFib or a flutter, paroxysmal supraventricular tachycardias, those are all be good indications to use something like diltiazem. So has anyone been an EMT before? There's a few. So you're like a DILT drip, starting a patient on a DILT drip. Like that's a very common thing. You have a patient who's coming in with supraventricular tachycardias or AFib or something like that. You can start a patient on this in order to help slow the heart rate down and try to get it to more kind of maybe not normal, but get to a point where you can sustain perfusion to the body, right? So this is a frequent one you'll see there.
Would they have this instead of nitro for that immediate release for angina?
No, for angina, this is going to be for long-term control of angina. So if you need an immediate vasodilatory action on those coronary vessels, like nitroglycerin is going to be the way to go with that. But DILT's going to be more for long-term control.
How come, sometimes I've seen it in the ER where they don't titrate it, but then when they send the patient up, they do titrate it. How come that happens?
It depends on what they're shooting for. So if they have certain limits on the order, so if it says titrate to heart rate of this, or titrate to make sure the blood pressure doesn't drop below this number or something like that. Depends on the goal and where you're at. Usually, when you're starting it, and I've seen certainly a lot of titration orders on this because you may start at the base rate, and most often because the IV form is pretty short acting, you'll have these patients on continuous drips, right? And so you'll get down, say you start at the beginning dose and the heart rate's still, sitting at 180 or something, you may need to gently increase that dose in order to help get the heart rate down. But usually the rate limiting thing here is going to be the blood pressure, right? So even if your heart rate's still high and the blood pressure is low, that's usually going to be your ceiling for how far you can drive that dose. But that's not really germane to this topic. So just looking at some of the pharmacokinetics of it. Big thing to note here is that the metabolites, notice it gets primarily metabolized by CYP3A4. That's going to be one of the big ones there. So note that drug interactions will be big on this. So lots of adverse effects associated with these drugs, especially if the dose is driven up too high or too quickly. So obviously you're going to see some vasodilation in the periphery. So you can see things like flushing, headache, hypotension, especially if your patients don't have like really good reserve. You can see peripheral edema develop and dizziness. Okay, that's one thing you can see there. You also will have the negative inotropic effects as well. So for those patients who say already have kind of a low resting heart rate, you can induce first degree AV blocks, bradycardia, and then potentially if they are, if they have CHF, they have impaired left ventricular function. By suppressing that, you can actually cause an exacerbation of their CHF by decreasing that cardiac output even further. So you'll typically see that although you may use something like a beta blocker for patients with CHF, typically you stay away from these non-dihydropyridine calcium channel blockers for CHF because of that decreased, trying to think of the word, the decreased contractility you see there, right? You will also see some adverse GI effects. Certainly you can see some nausea, vomiting, diarrhea, but constipation is usually one of the big ones here because you're impairing a lot of that smooth muscle relaxation and constriction, and that can happen in the GI tract as well. So constipation can be a big side effect for these guys. CNS-wise, most of the effects are going to be more related to CNS blood flow, but certainly you can see some fatigue, drowsiness, things like that. Can see gynecomastia and or sexual dysfunction for some of your patients. Don't have necessarily a good mechanism for that, but certainly you can see at least the gynecomastia aspect of it. But sexual dysfunction you'll find is a frequent side effect of a lot of antihypertensives, and a lot of it has to do with regulation of blood flow, different areas of the body. Other things you see is gingival hyperplasia as well. So it's kind of a unique one that you see with that. You'll see some other drugs as we come across them probably next semester that also have gingival hyperplasia. Basically, you just see the gums kind of just continuing to grow and can cover up some of the teeth. So contraindications, why you would not want to use diltiazem. They have an advanced heart block. Obviously, you don't want to make that worse. They have hypotension already. Don't want to make that worse. And then some relative contraindications. So heart failure would certainly be one, especially if they have kind of impaired ejection fraction, impaired cardiac output. Liver disease potentially, but you'd have to have pretty significant liver disease before I wouldn't use this. And then it can make your potentially GERD worse. So it could be something that's kind of a little bit more intolerable to your patients. So this is one of the big things I'll harp on here is going to be diltiazem and drug interactions. So what effect does diltiazem have on other drugs? And so we've mentioned 3A4 inhibition as well. Have we talked about PGP or P-glycoprotein? Probably mentioned it really in brief, but essentially P-glycoprotein is an efflux pump. So its main job is to keep drugs out of the body. If you see it up in the blood-brain barrier, it's important to keep drugs out of the CNS. And so you'll see PGP being important in things trying to be absorbed from the GI tract and basically spitting it back out into the GI tract. So by doing that, by effluxing it out into the GI tract, it prevents absorption. Things that are 3A4 inhibitors are typically PGP inhibitors as well, for whatever reasons. So like grapefruit juice is going to be affecting both P-glycoprotein and CYP3A4. But essentially, you're going to see the same interactions occurring when you have this occur. So when I inhibit CYP3A4, I'm decreasing metabolism of those drugs. So diltiazem can decrease metabolism of things like our statins, like we already mentioned. Other drugs like carbamazepine, which you can see for bipolar disorder or epilepsy, certain beta blockers. And then also the same effects are happening with PGP. So by inhibiting an efflux pump, I'm going to have more absorption of that drug, and let's drive levels up as well. So I can see interactions again with carbamazepine, digoxin, tacrolimus, other drugs like that. You can also see some pharmacodynamic interactions. So like we said, these are more kinetic actions with inhibiting 3A4 and P-glycoprotein, but as far as dynamic reactions, you can end up seeing kind of synergistic effects with other drugs that are suppressing cardiac tissue. So, if I had a beta blocker on board, or if I had something like an amiodarone, an antiarrhythmic on board, all of those can worsen either the heart block or potentially the hypotensive effects. So again, just like you'd imagine, by adding more hypertensives together, you get synergism there. So same thing can happen here. So other things that can affect diltiazem, so not only is diltiazem a CYP3A4 inhibitor, but it's also a substrate for that as well. So if I have other drugs which can inhibit 3A4, I can also drive levels up of this drug. So here you notice the VIR on the end. What do you think those drugs are? antivirals. You see those a lot with HIV medications. So a lot of HIV medications are 3A4 inhibitors, and so those are just some examples there. And again, the pharmacodynamic reactions, again, are going to be the same. Adding more cardiodepressants on board at the same time, you're going to see more cardiodepression occurring. The other non-dihydropyridine is going to be our Verapamil, and we'll see that it's pretty similar to Diltiazem in a lot of ways. Again, you're going to have this available IV, PO. Usually you're going to see SR formulations being used for more chronic control of things like hypertension. And you'll see that the indications are going to be very similar here as well. Hypertension, angina, supraventricular tachycardia, things like that. You can just to show the comparison here, very similar activity as you would see with Diltiazem. So other things to note here is that you do have some metabolism by CYP2C9, but the more important component here is going to be the 3A4 again. So you're going to see similar drug interactions as you did with Diltiazem. So we mentioned adverse effects, again, very similar to Diltiazem. Other big things you're going to see those is, again, constipation is going to be kind of even more pronounced with Verapamil than Diltiazem, so that could be a big issue for some patients. And everything else is pretty much the same here as we saw before. So again, therapeutically and clinically, you can lump Diltiazem and Verapamil pretty much together in your mind as far as things to remember about them. Again, similar contraindications. And then very similar drug interactions here. So again, they'll inhibit CYP3A4, they'll inhibit PGP, and very similar pharmacodynamic reactions here as well. And all the same here too. Okay, so then moving on, so those are non-dihydropyridines. Again, if you're thinking of something as being an antiarrhythmic or having effects on the SA node, AV node, think non-dihydropyridines. Now we have our dihydropyridines, which will include things like amlodipine, nifedipine, icardipine. Those ones are specifically marketed for angina and hypertension. You also have some other drugs, things like nisodipine, felodipine, isradipine. Again, those are pretty easy to identify if you were looking at them on a list, right? You even had some other kind of oddball indications. So one like nimodipine is actually approved for subarachnoid hemorrhage because it helps prevent some of the vasospasm that happens after a bleed like that. To see that a lot of these, if they're not long-acting just due to their half-life, you'll end up seeing that a lot of them are given as extended-release preparations because you generally want to avoid short-acting formulations just due to the pronounced effect that it will have on blood pressure. They will bottom you out real quick and then bring you back up if you have a short-acting agent. So very frequently you want to use either ones that have longer half-lives or ones that have controlled-release formulations. So again, mainly you're going to be thinking here as far as their pharmacologic effects is going to be on the vasculature. So you're going to be seeing mostly vasodilation happening here. Really very minimal effects on contractility and minimal effects on nodal conduction. Now again, this is all relative. If you were to increase your dose high enough to where you start to see some toxicity, it certainly you can see these drugs causing bradycardia, but therapeutically you really shouldn't be seeing those effects happening there. So most of them are pretty well absorbed, even though they have kind of chromium bioavailability. And you'll see that most of these are going to be metabolized by CYP3A4. They don't inhibit CYP3A4, but they are metabolized by CYP3A4. So that's an important distinction to remember them between the non-dihydropyridines and the dihydropyridines here, right? You should probably memorize everything on this slide. Just kidding, don't do that. Just to give you some examples of the differentiations here. So if you were to look at your half-lives of different drugs, you'll see that they vary pretty widely. So looking at something like nifedipine, they only have a half-life of 1.8 hours, fairly short-acting, versus something like amlodipine, 35 to 50 hours. So again, most of these medications are either going to be very long half-lives, so I can just take them once a day, or they'll be available as a controlled release preparation. And notice CYP3A4 substrates all the way down, but not necessarily, they're not going to be inhibiting 3A4 like you would see with your non-dihydropyridines. So adverse effects, you'll see that most of them are going to be related to this peripheral vasodilation. So peripheral edema can be a really big problem, especially for patients who have kind of poor circulatory issues anyway. And then the other thing, note here is this rebound tachycardia. So if you guys remember, anytime you drop your total peripheral resistance, what does your heart respond by doing? Pump harder? Yeah, so it wants to increase cardiac output, right? Because you want to maintain homeostasis. So one of the things you see here is that with your non-dihydropyridines, not only are they decreasing, the squeeze of the heart, but they're also decreasing the blood pressure as well. So you kind of have a balanced effect. Here with these guys instead, you're seeing primarily effects on the vasculature. So potentially what you can see is a rebound tachycardia as your heart tries to make up for that decrease in that peripheral resistance by increasing cardiac output. So sometimes patients will develop tachycardia related to that. You'll certainly see GI effects, nausea, vomiting, diarrhea, potentially some constipation there. And then also gynecomastia tends to be worse with some drugs than others. So something like nifedipine can be potentially really bad, even worse than diltiazem causing this. So again, for some of your male patients might be definitely not preferred. Really the only contraindications you're going to run into if you have severe aortic stenosis, because obviously if you have the aortic stenosis, you're kind of squeezing off the pipe a little bit, and then you have all this vasodilation occurring. It's going to be very difficult to keep perfusion up, so you would want to avoid it in that situation. And then also if you have unstable angina or recent MI, you want to avoid immediate release formulations, because that immediate vasodilation can decrease blood flow to the coronaries, decrease oxygen delivery, and can obviously produce new infarctions, so it's not good. So looking at the dihydropyridines effects on other drugs, mainly this is only going to be pharmacodynamic interactions because they don't inhibit CYP3A4 themselves. So certainly if you put it on board with other cardiodepressants or other antihypertensives, you're just going to see synergistic effects there. On the other hand, though, things that inhibit CYP3A4 can certainly have an effect on the dihydropyridine. So, usually you would never have diltiazem on board the same time as you have a dihydropyridine, but certainly anything that inhibits 3A4 can have effects on these guys. Okay, so any questions on beta blockers? I'm sorry, on calcium channel blockers. We haven't covered beta blockers yet. Okay, so moving on, beta blockers. So as you might imagine, what do these guys do? They block beta, absolutely. So essentially these are going to be competitive inhibitors of the beta-1 receptors and beta-2 receptors within the body. By decreasing the activity of beta-1 activity on the cardiac tissue, you're going to end up seeing decreased cardiac output. This is mainly going to be decreasing chronicity and the inotropy of the heart. You also end up having decreased activity of renal release due to blockade of the beta-1 receptors as well. So they can kind of have an indirect effect on the Renin-Angiotensin System. The other effects you can see are primarily related to the beta-2 effects. Usually beta-2, when activated, causes vasodilation and also can cause bronchial smooth muscle relaxation. So if I were to block the effects of beta-2 receptors, say in the lungs, I can potentially cause smooth muscle constriction, right? So that's why you always say beta blockers are contraindicated for patients with really severe reactive airway disease, because it might actually blunt the effects of some of their other medications. But anyway, this is where that bronchospasm comes from. They'll also blockade some of the presynaptic beta-2 receptors. These are autoreceptors that help blunt the release of further norepinephrine, which is good there. And then you can also see for some of these drugs, you'll see that their lipophilicity is going to be higher than others. And so some of them will have more CNS effects than others. And so you can end up seeing depression. You can end up seeing effects on things like migraines and whatnot. So lots of different effects. We'll talk more about them when we get to specific agents. So differences in our beta blockers, like why would you pick one beta blocker over another? Because truth be told, there's a lot of them, right? So one thing we'll talk about is selectivity. So when I say selectivity, what do I mean by that? In regards to beta blockers, we kind of mentioned it in glaucoma.
Type 2.
Exactly. So do they block specifically beta-1 receptors, or do they block all beta receptors? Okay. Remember, selectivity is all relative to dose. So if I increase my dose of a selective drug high enough, it's going to lose selectivity. So again, keep that in mind for any drug. Metabolism can be important as well. So some will have hepatic metabolism, will undergo first pass metabolism, have decreased half-life, things like that. Others will be more water soluble and will undergo renal elimination. So if you had patients that had renal dysfunction, it might be a reason not to use one of those. There's another component called this intrinsic sympathomimetic activity. I will say that clinically this doesn't really come up all that often, but it is certainly something that is good to note. Essentially, these will be drugs, these will be beta blockers that do have some inherent agonist activity. They're more like a partial agonist than a full agonist, and these can be potentially used for something like asthma and heart failure, symptomatic bradycardia. We'll talk about those a little bit later. You can also have some that will have more of this membrane stabilizing effect. So some of them will actually have kind of like a local anesthetic activity where they block kind of hyperactivity of some of these cell membranes, and so these are going to be more used for antiarrhythmic activity. So we'll talk about one specifically that does that. And then some of them will actually have some direct vasodilation. So in regards to selectivity, we'll talk about different generations of beta blockers, but we have this third generation, which has kind of a grab bag of different kind of miscellaneous effects. So some of them will help to increase nitric oxide production, which we know nitric oxide is vasoconstrictive or dilatory. Usually vasodilatory, so we can see some positive effects there. We'll see some alpha-1 antagonism, which blocking alpha-1 receptors should do what? Increase or decrease your blood pressure? Should decrease it, right? Because if I activate alpha-1 receptors, that should cause a squeeze on the blood on the vasculature. So you should see some decrease in hypertension there as well. Some will have beta-2 agonism effects. Some will block calcium channels. All kinds of different things. We'll talk about those specifically when we get to those agents. All right, so the first generation beta blockers that we'll look at, the thing that I mainly note that helps some students remember which ones go into which category is that typically N through Z, those are typically going to be your first generation non-selective beta blockers. A through M are typically going to be your second generation selective beta blockers. And then you have your third generation ones which don't really follow that rule, and you'll have to kind of learn those ones on your own. Sorry, there's always exceptions to the rule, but that's how it is. So if you notice here, the first generation non-selective beta blockers, most of them have that N through Z categorization. Things to note here, the lipid solubility I would make note of, especially if they're a very high lipid solubility, because those are drugs that are more likely to cause CNS effects. And so you guys have heard of the Beers list?
No.
No? So the Beers list is a list of drugs that you shouldn't give to old people because they can cause, they have increased risk of having some pretty nasty side effects. And so something like propranolol is bad for that because it can have these CNS kind of depressant effects because it's able to cross the blood-brain barrier pretty easily. So these would be one like you see worsening dementia, you can see nightmares and things like that due to the high lipophilicity of it. So that would be one thing to note there. But other than that, just being able to recognize whether a drug is a first generation, second generation, or third would be pretty good to know for testing purposes. Because I may ask, like, a patient who has asthma needs a beta blocker, which one would be most appropriate for them, right? That might be a question you'd want to be able to answer. Yes?
You said high lipid solubility has more potential to cross the blood-brain barrier?
Right, because your blood-brain barrier is basically a big lipid bilayer, and usually try to keep things out of it, but these ones are able to penetrate a little bit easier. Your second generation, as I mentioned, most of them will be A through M. Notice that none of these really have any real high lipid solubility. These are going to be more selective specifically for those beta-1 receptors. So you're going to lose some of the side effects that we'll see when we talk about the non-selective ones. And these you're going to typically see probably more often just for routine use for things like hypertension and whatnot. Notice you can tell if they're beta blockers or not by the LOL ending at the end. It's not that funny, so don't laugh out loud. Yeah. Then you have your third generation beta blockers. Notice these don't really fall into the naming convention. So these just kind of be able to point out. Notice some of these we've already seen with our glaucoma meds. So we notice cardiolol and betaxolol. Two other ones you'll see worth noting are going to be carvedilol and then labetalol. So carvedilol is going to be useful when we talk about congestive heart failure. That's going to be one you see that's going to be actually approved for that indication. And then labetalol is also a good one, especially on the inpatient side, because it's a very good agent. It's available IV. You can give it as an antihypertensive, very fast acting. So I'll see it's used more on the inpatient side via the IV route. But notice here there are other actions that they have. So things like carvedilol will block the alpha-1 receptors. It'll have some antioxidant, anti-proliferative effects. Which clinically, who knows if that's actually doing us much good. But labetalol, you'll notice that it blocks alpha-1 receptors, but also agonizes the beta-2 receptors. And we said beta-2 receptors are already vasodilatory in the first place, so you get really good antihypertensive effects via kind of a couple different mechanisms in that regard. So the indications for beta blockers, you're going to see there's quite a few different indications, similar to what we saw with the calcium channel blockers. There's kind of things you wouldn't necessarily associate with their mechanism of action, but hypertension is going to be a big one. Typically, you don't see beta blockers being recommended as first-line management of hypertension. We'll talk about kind of the hierarchy of drugs you should recommend for hypertension, but you will typically see these working better in younger patients, especially those that have kind of a ramped up sympathetic nervous system. So if they have a resting tachycardia, increased catecholamine release, increased renin, those would be a good patient for that. Typically, though, with younger patients, though, you're more likely to see exercise intolerance with these drugs. So, just being able to run up a set of stairs might not be a problem for you normally, but being on a beta blocker, all of a sudden you might get real winded by the time you get up there because your heart just can't keep up with the oxygen demands by the body. So keep that in mind for as far as when dealing with younger patients. So looking at the beta blockers, so we've seen kind of these graphs before, but looking at use of the drugs. So you see there the mean arterial pressure, you see the cardiac output, and then you have your total peripheral resistance that's occurring there. So I want to look at some of the chronic changes that you're going to see with beta blockers when you're administering them. So obviously that dotted line down the middle is going to be separating kind of your acute use of beta blockers versus more of your chronic use. So with your mean arterial pressure, say give a dose of the drug, you should start to see some decrease in essentially your mean arterial pressure may stay the same for some period of time, because even though you're knocking down your cardiac output because you're blocking the beta-1 effects on the heart, typically your blood vessels are going to respond by increasing that total peripheral resistance, right? So similar to what we saw with our calcium channel blockers, the dihydropyridines, this is kind of the opposite effect. So even though I'm kind of blunting the heart, I can end up seeing increase in blood pressure, so that way to the point where your mean arterial pressure doesn't really change, right? That makes sense to you guys? The vessels are squeezing more because the heart's not pumping as hard, right? So your mean arterial pressure really stays the same. Over time, though, what you're going to see is that the total peripheral resistance will actually go down with chronic use. Cardiac output should kind of normalize for the most part, or stay a little bit lower if you have one that's like really non-selective. And thus, with more chronic use, you're going to see your MAP actually go down. Right, so it's maybe something that takes a little bit of time before you actually see the true effects of it occurring, and a lot of it has to do with the chronic effects of things like that altered baroreceptor reflex that we see that was really important for releasing renin and all that. So some of the main antihypertensive effects will take time to really kind of solidify.
The ISA.
That's that intrinsic sympathomimetic activity. Yeah, so there's very few of those drugs that really had a lot of that activity. So clinically, we're not really going to focus too much on it. Okay, so other clinical indications, we already mentioned glaucoma, so I won't really kind of belabor that point. Some patients may use this for migraine prophylaxis. You'll note that for some patients this may actually induce migraines, so this is really more for prophylaxis rather than actual acute treatment of migraines. Some people think it has to do with preventing some vasospasm from occurring. Lots of different mechanisms. We're not really sure really what it does. But notice here, propranolol is probably the better one to use for that, just because it's better CNS penetration. Because remember, it had that high lipophilicity. Propranolol is probably the poster child for beta blockers that have good CNS penetration. So I'll just say that because I don't use most of my examples. Will use that. Potentially you can use beta blockers for thyrotoxicosis secondary to hyperthyroidism. So again, when you have thyrotoxicosis, you really just have a super ramped up sympathetic nervous system. So beta blockers are good to blunt some of those effects by blocking those adrenergic receptors. So it can help to decrease some of the tachycardia, the tremor, and the anxiety the patient's feeling. And actually, some of the effects also come from helping to prevent conversion of T4 over to the more active T3. So it's like kind of a bonus benefit. So if you ever see propranolol being prescribed for thyroid storm or something, that's part of the reason why they're doing it, is to help prevent that conversion. We can also see beta blockers being used for angina. So again, by decreasing a lot of that squeeze on the blood vessels, you can help to increase cardiac blood flow. You can also decrease the oxygen demand by the heart by decreasing natural chronotropy and the inotropy of it. So all those things can kind of help decrease the load on the heart. And then for a lot of patients, by using chronic beta blockers, they can actually increase the time associated before they develop angina. So you can increase their exercise tolerance to some degree. You can utilize beta blockers with acute myocardial infarction. So this actually helps to prevent some of the ischemic effects from the norepi and the epi that's being released during a myocardial infarction. Helps to decrease O2 demand, which again is usually part of the inciting event when you're having an MI. So obviously, if your patient is to the point where they're already bradycardic or potentially almost coding, you don't want to give them beta blocker right then. But very frequently, you'll end up seeing them being put on beta blockers in the post-resuscitation period. We'll talk more about that in the next cardiac section. And then supraventricular arrhythmias would be another good indication for these because, again, they're directly affecting the SA node and the AV node by blocking those. So better for supraventricular tachycardias. You can also use beta blockers for acute panic attacks. So certainly, if you have performance anxiety and things like that, this is useful for blunting a lot of those central nervous system or sympathetic nervous system effects. So especially in school, I knew a lot of people who were prescribed beta blockers because they got very nervous when they had to stand up and talk in front of people. And so this helps blunt a lot of that extra norepinephrine and epinephrine being released from the CNS when you're freaked out about to talk in front of a bunch of people. And it can also help with the essential tremor as well by blocking some of those beta-2 receptors on the skeletal muscle. For CHF, there's only really 3 beta blockers that are recommended for that. So notice here that it's going to be carvedilol, bisoprolol, and then I should note here specifically it's metoprolol extended release. So we'll talk more about metoprolol. There's an extended release preparation that's available. And they actually have found that even though typically beta blockers are not recommended for CHF because you don't want to decrease someone's cardiac output, right? They already have bad left ventricle. What they actually end up seeing is mortality benefits over a long period of time. So typically you'll end up seeing these patients start on very low doses of the beta blockers and then gently titrate it up as far as their tolerance will go for it before side effects kind of get too bad for them. We'll talk more about that when we talk about CHF. As far as adverse effects go, bronchoconstriction can be a big problem, especially with our non-selective beta blockers. So you worry about patients who, say, have an asthma exacerbation. What's your first go-to drug for that? No one has asthma in here? Albuterol is usually your go-to drug when someone having an asthma attack, right? It's a beta-2 agonist. Someone has to be asthmatic in here. Usually something like albuterol, but that acts as a beta-2 agonist. And if I have a drug on board that's blocking those receptors, then potentially my drug's going to be less effective. You will typically see that the beta-1 selective agents, while not 100% selective, are selective enough you don't really see this interaction. So those are typically safe for those patients who have really severe reactive airway disease. For patients who, obviously you're going to have some cardiodepressive effects from these drugs, so you're going to have this negative inotropy, so exercise intolerance, you're going to have fatigue that can occur, run the risk of developing AV block, bradycardia. Those are all definitely possible when having these beta blockers on board. You will also see some disturbed glucose metabolism that can occur here. So certainly if you were to have, say, a type 1 diabetic who, again, is not producing really any insulin on their own, this can actually lead to hypoglycemia. And a lot of this is due to the fact that there's lots of beta receptors on the liver that's responsible for things like glycogenolysis and gluconeogenesis. And so by blunting the effects of the beta receptors on the liver, you actually have less glucose being made. And so those patients who, again, are kind of not super able to regulate their blood pressure or blood sugar that well, they can end up having hypoglycemia because of this. The other thing is that the beta blockers, if you imagine someone, is anyone blood sugar ever run low, like what do you feel like? Tired, you feel, you get kind of sweaty and clammy and you get really cranky. Well, a lot of those symptoms are kind of masked by beta blockers. So if you don't have that skeletal muscle, you don't get that tremor, you don't really get the sweating so much. So your patient can be hypoglycemic and not really know it. Right, so that's one of the dangers of having beta blockers on board potentially, is that they are developing hypoglycemia. You can go miss for some period of time. And then for type 2 diabetics, you actually potentially see hyperglycemia occurring because beta blockers can actually prevent some insulin release from occurring, which again, that's going to lead to higher blood glucose levels. So it can make it a little bit more difficult to control those patients. Okay, you can also have impaired peripheral circulation. So by blocking the beta-2 receptors in the blood vessels, this can actually lead to things like worsening Raynaud's phenomenons, where you get those the changes in the and you go from like hot to cold temperatures and things like that. Your fingers start turning a little purple. Can lead to skeletal muscle fatigue, and then worsen this peripheral artery disease. So they can have worsened intermittent claudication for those patients. That's definitely a big thing to know. There's kind of a relative contraindication for them. And then if you were to have sudden withdrawal of these beta blockers, because if we're blocking beta receptors, what do the receptors want to do in response to that? Upregulate, right? So you have more beta receptors now to activate. If I have a sudden withdrawal from that, I can actually see big spikes in your blood pressure, heart rate, which can lead to increased oxygen demand, which can lead to angina, MI, all that kind of bad stuff. So typically you do want to have a taper for these drugs when you're coming off of them. And then as far as CNS effects, you can see with the highly lipid-soluble agents, you can have worsening depression, you can have nightmares, really vivid dreams, and so by switching over to a less lipid-soluble agent, you're going to get less of those effects there. So typically for like elderly patients, you'd want to focus on more using more water-soluble beta blockers. And then it can also have some negative effects on your triglycerides.